Hello, everyone. I am Salim Virani, and I serve as Vice Provost for Research and Professor of Medicine at the Aga Khan University in Pakistan.
And I'm Kristin Newby. I'm a professor of medicine in the Division of Cardiology and a faculty member at the Duke Clinical Research Institute at Duke University School of Medicine.
So, we are so excited today to be talking about the 2023 American Heart Association and American College of Cardiology guideline for the management of patients with chronic coronary artery disease. Now, the other important aspect is the use of antiplatelet therapy in patients with chronic coronary disease. A general principle is that shorter duration of dual antiplatelet therapy is safe and effective in many circumstances, particularly when the risk of bleeding is high and the ischemic risk is low to moderate. So, with that being said, the approach depends on the type of patient. In patients who have CCD and a PCI that was performed, we have a class 1 recommendation to use dual antiplatelet therapy or DAPT consisting of aspirin and clopidogrel for 6 months post PCI, followed by single antiplatelet therapy. Now, if needed, there is also a class 2 recommendation in these patients if they have a drug-eluting stent and if they have completed 1 to 3 months of DAPT, that one could consider a P2Y12 inhibitor monotherapy for at least 12 months. So that is also an option, especially if we want to reduce bleeding risk. So in patients with CCD and no indication for oral anticoagulant therapy, we also have a class 1 recommendation for low dose aspirin therapy. And that, of course, is recommended in most patients with chronic coronary disease. However, in patients without recent ACS or those who have not had any PCI related indication for DAPT, the addition of clopidogrel to aspirin therapy is not useful to reduce MACE. And last but not the least, we have a class 3 recommendation, which is a very strong recommendation to avoid NSAID use, at least especially long-term NSAID use in patients with chronic coronary disease, because we know that long-term NSAID use can increase bleeding complication and also increase the risk of cardiovascular events in patients with CCDs.
In patients who have undergone elective percutaneous coronary intervention and who require oral anticoagulant, we should have dual antiplatelet therapy or DAPT for 1 to 2 weeks. That's then followed by clopidogrel alone for 6 months, in addition to that DOAC. Further, in patients who need an oral anticoagulant and have a low atherothrombotic risk, we can discontinue aspirin with continuation of the DOAC alone for a year after PCI, and dropping the aspirin is to reduce the bleeding risk.